over, toggle down to the bottom. There's a mute button, start and stop video, the chat feature. So if you want to type in a message to let us know that you can hear us, and to also add any questions or who you are and where you're joining from, that would be great. Just go ahead and use that. We will be using this chat feature throughout the duration of today's webinar for any real-time questions, comments. So Amy Moraski is going to be facilitating the questions at the close of today. We're going to wait just another 30 seconds, minute before we get started, and just go ahead and add us in. So I see the Valleywide team is joining, so thanks so much. If you're joining from another state or organization that is not directly connected to CCSP, would love to know who you are too. So join us here in the message. While we're getting everyone on, just as a reminder that this is the third in the series of the stool DNA, in the fecal test stool testing webinar series. We had Dr. Dorado Brooks talking about the evidence base, the lay of the land, the Fight CRC team present on patient perspectives and patient preference, as well as advice from the patient community to the clinical teams about moving ahead with implementation of stool-based testing. Today we'll be talking about the implementation side based on clinic experience and the work at our health department with several of the clinic systems who I think might be on. Next session, we will be talking a little bit further about evidence-based interventions, further relevant to FIT and FOBT, as well as other stool-based testing. And then Amy, I believe then we will have one more session talking a little bit about that movement from positive stool-based testing into other types of screening. Does that characterize it well, Amy?
Yes, that is correct.
Okay, great. So all that to say that we have 2 more sessions coming in this series, and a huge thank you for everyone who's been engaged in this and all of our presenters as well. So it looks like we have about 20 plus people joining right now. So we're going to go ahead and get started. And again, thank you to Meg Phillips from the Health Department for sharing perspective. Also going to share a little bit about the CQI quality control work connected as well. So we're very grateful to have Meg as part of our colleague and our team that we work closely with at the Health Department, engaging and sharing the work today. Amy, anything else before I pass it over to Meg today?
We are ready to go.
Okay, great. So Meg, on behalf of CCSP, we're super delighted to have you. So take it away.
All right. Thanks for the introduction, Andy. Can everyone hear me okay? Sounds like it, hopefully?
Yes.
Perfect. Okay. So my slides, I think Andy did a really nice job of kind of laying out the whole series, and I do touch on some pieces. I wasn't sure if all of the participants registered and were able to attend all of the series, so some of this might seem a little bit redundant or things that were covered a bit more in depth, but I think that will just help us kind of frame our conversation that we're going to be having this today. Go ahead to the next slide, Amy. So a few things that I want to talk about is I'll give an introduction of myself and kind of who I am and why I'm here today. My experience with implementing stool-based programs within clinics, and then I actually have a workflow from one of the sites that I work with, and I think they actually might be on the call. So that is more around the work that I had implemented with them regarding FIT and FOBT, and just kind of what are the practical implications of this, and what are some of their outcomes data, and then just a few lessons learned and resources. So my slides are actually fairly short. I'm hoping that we'll have plenty of time at the end to answer any questions or talk through this. I'm also happy to think through anything regarding how people could start implementing a FIT and FOBT program at their clinic. And I also have my contact information at the end of the slides. If anyone wants to follow up with me, I'm happy to help however I can. So next slide, perfect. Yep, this is just our information. Andy, again, thank you so much for having me and the introduction. I work at the Colorado Department of Public Health and Environment, and I run the colorectal cancer control program, which is funding that we receive from the CDC to do colorectal cancer control in the state. By no means does CDPHE do this alone. It helps fund a lot of our health systems change work at the state. We also compare combined funding to better support our grantees with breast and cervical cancer funding, since a lot of the evidence-based interventions for colorectal cancer are also for breast and cervical. So I am lucky enough to help manage and lead this program, but by no means am I doing it by myself. So I also am the clinic quality improvement lead for the Cancer Prevention and Early Detection Grants Program, which has multiple strategies, and CQI just happens to be one of them, which is another term for health systems change. And I'll talk a little bit about CQI, so and what that is and what's it mean. I also co-chair the Colorectal Cancer Task Force for the Colorado Cancer Coalition, and then I help manage our federal funding. Next slide. And I think really what the programmatic implementations of clinic and quality improvement look like is really on this clinic quality improvement side of things. CQI is what I'll probably refer to it throughout this presentation, is really, can be a lot of things. CQI is often within large health systems, it's in community health centers, it's has components of patient safety and quality. And I'm just gonna explain what our current structure is and how we do clinic quality improvement, leading to increased colorectal cancer screening rates. So we have Dr. Dorado Brooks, I'm sure, discussed the community guide and the evidence-based interventions that actually increase cancer screening that can be implemented at clinics. So how I like to think of this, I'm sure we've all had an IKEA table that we've wanted to put together, and it's very complicated or not very intuitive, and the evidence-based interventions in the community guide out there are basically the instructions on how to build the table. They tell you what they know is going to work. There's evidence to back it up. And then improvement science, or clinic quality improvement, is a well-tested methodology. It's a science, really, and that's basically the tool belt. That is what is going to help you put everything together, help it be nice and strong and sustain it, and make sure that none of the important pieces are missing, and then you have all the right tools. And then ultimately, increase cancer screening rates, or colorectal cancer screening rates, and the better patient care and reduced cost and improved outcomes. That's the table itself. That's the output of all of this. So, so there's a lot of different components, but they all are hopefully driving to better patient outcomes, resulting in increased cancer screening rates. And it is a built, sturdy program that will go through lots of different dinners and lots of different guests, but will hopefully stand the test of time. Next slide. So this is just a quick process of what CQI can kind of look like within a health system. And the nice thing, and I think also what can be confusing, is that clinic quality improvement does not necessarily start in one perfect spot. You can identify a problem with anything. You can be trying to cut down on your commute to work, and you could notice that this takes really long, and you could try to do a quality improvement project surrounding your commute to work and track data and think about this, but there's not one perfect starting place. You can identify a problem, something can become a problem, you want to implement something new within a clinic, and those are all really great starting places for implementing quality improvement methodology to address a need to ultimately improve an outcome or goal or process or eliminate waste. And there's a few different terms that are sometimes used for clinic quality improvement. There's also something called lean, and there's something called Six Sigma. A lot of it is built off of the same foundation, but we use clinic quality improvement because it is more focused towards healthcare and patient outcomes. So one of the first steps is, like I said, you could find a problem, you can identify a problem, you could, and this could be anything from you see that you have low colorectal cancer screening rates, you have low FIT return rates, you could see that there's multiple orders being put in. It's really anywhere that you see that has to do with an issue that you'd like to improve. Then you would think about the problem and assemble a team. I think the really critical piece of clinic quality improvement is that this is team-based. Clinic quality improvement cannot necessarily be done by yourself. Most times it touches a lot of different people along the whole process. It requires a bunch of different perspectives, and that every perspective and everyone's opinions and thoughts really are valued within clinic quality improvement, and they're all working towards the same thing, which is a better process, increased colorectal cancer screening rates, and better patient outcomes. So how the process affects everyone is a little bit different, but everyone's views are super important to have the best possible process to increase cancer screening rates, or, you know, a FIT program. So I'm talking a little bit more about clinic quality improvement because that's ultimately going to lead to my experience with FIT testing and FOBT program implementation within the clinic. So this is very much my lens. And then step 3 would be to review data, see what this has to do. Why is your number so low? And we'll talk a little bit more about step 3, 4, 5, and 6 kind of as we progress in the slides. So next slide, please. So why clinic quality improvement? Why FIT and FOBT programs? So really where they cross is within my role, I work with a lot of federally qualified health systems or safety net clinics to think about how we can work with patients to increase cancer screening rates. And a lot in that lens is very much clinic quality improvement. So I have not been in the clinical setting for a few years. I work with people that are in clinical settings, and we do process implementation and clinic quality improvement together to ultimately get to that built sturdy table of a functioning process, a good workflow to support their patients to complete screening. So my lens is very much through how this is implemented in a clinic from a clinic quality improvement perspective. And so just a few things to kind of reiterate as we're talking about this is that when I go in to work with the clinic or partner with them, we review guidelines and think about who should be receiving FIT and FOBT programs, who that patient population is. That's not going to be everyone based off of family history, symptoms, average risk or high risk, and age. And also, there's a lot of barriers or shared decision-making that should be happening regarding FIT and FOBT programs, and just it's colorectal cancer screening as a whole on determining which is the best test for them. So since this is a FIT and FOBT series, we're going to be thinking about that program. So I think it's really important to understand who are the patients that are going to benefit from this program and implementing a FIT and FOBT program within a clinic, and what does that mean? So how are we going to track this data? How are we pulling this data from our electronic health record? All of those things are going to help determine where A, our starting point is, and B, if we are meeting the right criteria in terms of starting a quality improvement program. So FIT and FOBT are also some of the most common types of colorectal cancer screening testing. I'm sure Dr. Brooks covered a lot of this within his presentation, but this is just a few things to keep in mind, because ultimately there could be a different process for those that are high risk that should really be referred to for colonoscopy compared to starting with a FIT and FOBT program. And FIT and FOBT should be completed annually, and the adherence to this is really important just because of the specificity for human blood and lower GI bleeding, and that it needs to be tested for annually, and there is no delay in terms of completing screening like there might be for a colonoscopy. Once that's done, if they're perfectly normal and they didn't have any polyps and your average risk where it might be 5 to 10 years, which it sounds like Andy and her team are going to be covering and a different presentation in this series. So these are also things to keep in mind when you're thinking about this clinic quality improvement and implementing the programs. So how are you going to track this data annually? How are you going to monitor adherence? Making sure we're targeting the right patients and we aren't recommending fit and FOBT to those that maybe are high risk. So understanding the who is going to be and when is important with any program, really. Next slide, please. Okay, so now we come to the why. There's a lot of advantages to fit and FOBT. And I'm sure the FIGHT-CRC team maybe took into consideration the perspectives of a fit and FOBT program, but this ultimately is also going to help bring in that patient perspective to clinic quality improvement or program implementation on how you support patients to then complete screening. So it's important in terms of understanding so that you can have messaging to support their decision, making sure that you're framing the project to your team and leadership, and how you implement the program is going to be really important. So understanding the why is, I think, a pretty early critical piece in the overall clinic quality improvement process. And there's a lot of advantages in logistics to think about when you're thinking about an overall fit and FOBT program. This is less price, prep for completing screening, and then privacy are a lot of advantages. So this is much cheaper for a lot of patients. They don't have to take time off of work to complete a prep or then go into a hospital or endoscopy suite to complete to have the test done, and it's done within their privacy of their own home. And the why in terms of this is going to help support patient decision and ultimately, I think, patient tracking. And then there's a lot of logistical aspects of why people would choose fit and FOBT within a clinic. It's non-invasive. Risk is something that everyone should be considering with pain and bleeding and perforation, even if it is very low with colonoscopies. And understanding the limits for colonoscopies and fit and FOBT are also going to be important. So when we're thinking about implementing a program, understanding and making sure that we're providing education and supporting materials to make sure that people understand what fit and FOBT is, what it means, what are the requirements, is ultimately also going to help in terms of increasing adherence to screening recommendations, but also the output of this. Okay, I have one more slide until we're going to really talk about what this could look like within a clinic. Next slide, I think, is the how. Perfect. So this is really how do we do this? So a few key takeaways that I just covered in the last couple of slides are understanding your population and in your clinic. What is your current process? So what's the starting point? Do we have a process within our clinic to identify patients that maybe are due for cancer screening? What is that process? Is this really what we're doing? And then how can we support, improve, or track whether this process is actually working? So the next one is going to be identifying that population. So who should we be targeting? Who should we be monitoring when they come in for, their sore throats, that they are also due for cancer screening? The next one is identifying that population and really making sure that you understand who they are. So when they come in, you can initiate that process pretty quickly. If it includes, maybe handing them out fit testing, that sort of stuff. And then the final how of implementing a fit and FOBT program is really developing, testing, and promoting the process within your clinic to everyone. So if you remember a few slides ago, how a lot of times clinic quality improvement is meant to be a team-based intervention and process, and that really anyone who sees the patient, so front desk and check-in and the medical assistant or nursing staff, and then the provider, and then the ultimate like clinic champion, all of those people are going to have space and a role in developing what the process looks like. Whether you're just making sure the current process is working, or you have some low screening rates that you would really like to improve. What are we currently doing? Who should be on the team? And what should our new process look like? And then testing it. So how do you know if an improvement is made is a common question I often ask myself when thinking about clinic quality improvement and all of the work that we're doing. You know, how can we track some data, which is obviously incredibly important to understand whether an improvement was made. And are we working in the clinical setting with the right people? Who are we missing? Should we involve our practice manager? Should we involve all of the MAs? That is ultimately going to help make any program for clinic quality improvement and any FIT and FOBT program really thrive. Okay, so let's see here. I think we're ready to go on to our next slide. Okay, so next I'd like to talk a little bit about what this could look like. So we have an example from Clinica Tepeyac, who I think Olga is actually on the call. I have worked with them for a long time. They're a great partner to work with. They're also really focusing on what FIT and FOBT looks like within their clinic. And so I'm just going to share a little bit about their process and what that looks like within the clinic. Next slide, Amy. So this is a beautiful workflow, and hopefully everyone can see it okay. This is a new process. So they had previously looked at their colorectal cancer screening rates. They were trying to figure out maybe how to improve their screening rates and what would be the best thing to ultimately support their patients, but think about how they get the FIT testing returned to them, either to the clinic or through a partner lab that they work with. So I'm just going to walk through this. So the provider enters the current order for a FIT and FOBT testing. It's nice in here. So the circle at the top left is where we're starting, sorry. And so they also have ICD-10 codes and CPT codes in here, which is also helpful. So the more information and detail that we add to any workflows to support either decision-making or critical information ultimately will also help make the process more smoothly. And then the next step is that the MA fills out a request and provides a FIT and FOBT kit to the patient. And provides education on how to perform the test and return tests. Then the next step is there's a $10 payment that comes with completing FIT and FOBT testing, and that is collected, I believe, at the front desk. And then from this step, the patient goes home, collects the stool test, and completes the test from 3 different valve movements if it's an FOBT, and then they return the test. So the test can either be returned to the clinic, and the MA might also contact the patient and remind them. I think that this is often where health navigation can play a really critical role in terms of navigating patients to complete screening, but also how can you leverage other staff within the clinic to send out those reminders and make sure that they are aware that this is important, this is something they discuss with their provider, and that they should complete the test and return it. And then it goes into whether they were able to contact the patient and discuss this, or if they were unable to. So if they do reach the patient and the patient returns the FIT and FOBT test, it can either be returned to the clinic itself, or it can go to Quest Diagnostics. And if they are unable to reach after 2 calls and a letter, it kind of will start the process back over. And it could be then like kind of reflagged when the patient comes back in. The next part is if they do return, say it is returned to Quest. And this is very detailed regarding return because we had found in working together that there was actually a lot of kind of bumps in this process that have since been worked out, which I'm going to share on my next slide. But so the fit test is then returned. Trying to make this as easy for the patient is obviously the goal. That's going to lower barriers to complete screening and then hopefully increase adherence to complete screening. So the order is either placed, processed, and then overall the results are sent back to the clinic, determining on whether they are negative or positive, making sure it's completed correctly. And then the provider ultimately could create a colonoscopy referral into the EHR depending on what the outcome of the FIT and FOBT test is. Okay. Let's start with the next slide. Okay, so what did we learn in this process? How did this all come about? What was the purpose? And then what are the outcomes? So when this was first implemented, there was, based off of the current progress or the current kind of process and workflow, there was a lot of duplicative orders that were being put in place either by Quest or by providers. And so really when they were looking at their population as a whole, thinking back to identifying the who, the what, and how, there was a larger number that actually didn't need as much screening as their data suggested. So there was a lot of duplicative orders for FIT and FOBT. There was one from the clinic, one from Quest Diagnostics, and it just ultimately lowered their screening rates, which it can have pretty serious implications in terms of why you're identifying and working on a project. And ultimately knowing your true numbers and accurate data is also just going to improve care and how you support your population and manage population within your clinic. So accurate data is a pretty key takeaway, and how that's managed and pulled it's a long topic. It might have to be a different series, but it's ultimately going to be important not only to making sure that you're doing the best thing and thinking about your patients, but ultimately reporting for a lot of grants. It can just be really burdensome if you're not collecting accurate data. And this is not a new groundbreaking statement, and this is something that a lot of clinics are really focusing on, and that's ultimately going to just help better understand your population and the barriers that they have in terms of completing screening. So thinking about the full process, what data you have, and then also managing the workflow and thinking about once you map it or once you're going through and testing this, is this really what we're doing? Are we missing anything from any of our providers? Do we actually have a patient navigator that should be more involved within this process? Is this documented workflow really what we should be doing, what we are doing and what we should be doing? And then testing it, and is it working? Those are all things that you should really be considering when you're thinking about either implementing an evidence-based intervention or managing a workflow, thinking about the team and if this is really accurate, and really what's the comparison? What are we currently doing with what do we want to be doing, and where are the gaps and what needs to change for us to get there? And then testing it and trying to come up with the best possible process to understand how has this changed our patient population and ultimately our screening rates. So next slide, please. So when Clinica Tepeyac did this, actually, sorry, Amy, can you go back one more? So when they took a look, they followed these steps. They were understanding their data better. They were thinking about their population. They were mapping out a workflow or looking at a workflow, and it wasn't really capturing all of the components that affected the patient and ultimately the clinic. And in doing so, they had a 2 to 3% increase in colorectal cancer screenings within 1 month, which is pretty incredible. And I think that is attributed to not only thinking about colorectal screening rates and clinic quality improvement and how do we improve this within our clinic and how do we make this process better, but the multidisciplinary team-based approach to how this was implemented was pretty remarkable. If you have more people, as many people thinking about a process within a clinic, you're more likely to identify where gaps are and where an improvement can be made, which will ultimately affect the outcome. So it was a really incredible process to watch unfold and also see how this has changed in the coming months. So this was in the fall. And even since then, since this workflow has been implemented, there has been pretty remarkable achievements, not only in how the evidence-based interventions are being implemented, so how they're supporting patients, how this work is being done, and what the next step is. So they developed a workflow, they got their data where it should be, and so that they can monitor an improvement. What are we going to do now? And that could be anywhere from standardizing one-on-one education for FIT and FOBT, doing targeted patient reminders via your electronic health record, thinking about providing our supplementary information for FIT and FOBT testing. So a lot of this is kind of the first step. And then once you get to a point, there's a lot of things that can come about that. So next slide, please. So a few lessons learned just from my work, not necessarily with any particular clinic, but meeting patients where they are at in this process is also really important. So how can we provide instructions with pictures, make sure they're English and in Spanish to better support and make this process easier for them so they know exactly what they should be doing to complete screening for FIT and FOBT. One clinic that I work with makes FIT and FOBT kits so that when they are in the clinic room, or in the room with the patient, they actually have a kit that they can provide to the patient with accurate information, return instructions, and so you don't necessarily have to delay them getting screening, and they can actually walk out the door with that today. So making this as seamless as possible, not only so that your clinic can run as smooth as possible, but that your patients have everything that they need. So they don't have to call and say, I'm confused, or that my test is expired. I'm not sure, can I mail this? Do I have to return it? There's a lot of things to think about in terms of the patient experience to ultimately get them across that finish line of completed screening. There was a pilot program in the state of Washington that actually provided stamped return envelopes for people to mail in their FIT and FOBT testing. And the data for that is also pretty impressive, especially thinking about populations that maybe have transportation barriers. Those things are ultimately going to help make completed screening easier for patients. And then I think the big component is the follow-up reminder that they have everything they need, and we really just need them to complete the test and either mail it in or drop it off at the clinic or Quest Diagnostics. Reiterating the message multiple times can also complete screening. And as long as that message is the same and accurate and is targeted and to a level of health literacy that's appropriate for your patient, is going to make this process better for them and ultimately also increase colorectal cancer screening. Okay, next slide. I linked in here some really great resources. My slides, it sounds like, in the recording of this will be available on the CCSP's website. So there's a few different ways that you can implement programs. One of them was including a flu FIT program. So since FIT is annually, everyone hopefully comes in to get their flu shot annually. How can we kind of pair an already marked example of something that needs to happen annually with FIT testing? There's some information about best practices for cancer screening, and then thinking about this in terms of the community health centers. and then some previous slides actually from Dr. Dorado Brooks on how FIT and FOBT testing are the preferred mechanism for patients, and what does the support and evidence look like for that. And I think that's it. I talk very fast. I hope all of you caught that. And it looks like we have plenty of time to answer any questions about any aspect of this. So I'm not sure, Amy, do you want me to hand this back over to you?
Yeah, so at this time, we welcome you, like she said, to answer any question or ask any questions. You can type in the chat, or we also welcome you to unmute if you prefer. Any insight if your program is utilizing FOBT and you have something that has worked well, we would also love to hear some insight from things that you've been doing. So anything that you share, any questions, go ahead and please ask away. We will also in just a minute be putting the link for the evaluation in the chat, also very important. So please take a moment as soon as that gets posted to go ahead and answer just a couple of questions about today. So with that, I will mute myself and give people an opportunity to ask some questions. And Olga, I do see that you're on. So if there's any insight or anything else you would like to add about the great work that Meg highlighted, we welcome you to comment on that as well. Okay, we have a very nice shy group today. It happens, that's okay. So Elsa right now is putting in that link. So again, please take a moment to fill out the evaluation. It really does help us a ton. If there's any questions that you think of after the fact, Mag's information is up on the screen, and also you're welcome to reach out to us and we'll connect you with her. Olga, we do not hear you. Try speaking now, Olga.
Can you hear me now?
Yes, perfect.
Okay. I was just saying that, Meg, you did a fabulous job explaining our process, so I appreciate it, and thank you very much.
Yes, I'm happy to. I discussed this and with your team on Wednesday, so I hope it wasn't a complete surprise that I was sharing an example of you and your clinic's work. But I think that if you have any insight that you would like to add that I maybe had missed, I think that that would be a great addition, knowing that you were more involved with the actual implementation and the application of this process. So no pressure though.
Yes. No, I think I've kind of been hands-on since Gabriella stepped into the QA position. So I've been helping with some of the implementation at the clinic level, but I think all in all, we're coming along.
Yes, definitely. And I think also that clinic quality improvement is really meant to be continuous improvement, and the work that you are all working on now and kind of where you were is a very nice progression in how just really that first step should be understanding your population and understanding your data, and then building off of that by thinking about maybe we should be implementing some evidence-based interventions, which Olga, you and your team are all doing very well. But if you are at all interested in improving your clinic screening rates for FIT and FOBT, that's the real foundation of
Right.
just understanding where an improvement can be made, and a lot can build off of that. But we also know that multiple evidence-based interventions ultimately also increase cancer screening rates. So how can we also do very specific messaging for our patients and client reminders, but also remind our providers that they should be talking about this and providing that education? All of those things are ultimately going to be very critical to increasing not only FIT and FOBT completion rates, but increasing cancer screening rates as a whole.
Yes.
Thank you so much, Olga. We appreciate your opinion on this as well. So I haven't seen any questions come up in the chat. Again, you are welcome to reach out to our team, and you're welcome to reach out to Megan directly and ask anything that comes up later. I know I'm one of those people that'll think of something 10 o'clock tonight. So feel free to reach out if you are also that person. Again, one last reminder, the evaluation is in the chat. And with that, I think that we are ready to close. Megan, thank you so much for taking your time today. We really appreciate you. You guys, she has just been a huge proponent for our program and for this work in general. And she's just a great champion. And so we're excited to have her with us today and just have her working alongside us with everything we do. So thank you so, so much for joining us. We really appreciate you.
Yeah, of course, I'm happy to. Thanks for letting me talk at lightning speed for 45 minutes today. I hope everyone has a good Friday and a great weekend, and I'm happy to hang out for a few more minutes if anyone has questions, or feel free to reach out to me directly.
Wonderful. Thank you all. Have a wonderful rest of your day.
Thanks, ladies. Have a great weekend.